todos, bom dia, boa tarde. Estamos iniciando a nossa webinar. Eu gostaria aqui de agradecer muito à nossa equipe de ensino Einstein, que organizou a reunião científica para nós, a coordenação da materna infantil e medicina fetal aqui do Einstein e ao Laboratório de Genética do Einstein. Eu vou apresentar os participantes e a nossa palestrante. Nós temos aqui a doutora Renata Minilo, ela vai ser a debatedora. Ela é geneticista do nosso laboratório aqui do Einstein, faz parte do laboratório, mas também atua clinicamente aqui. E ela vai arguir e debater com a doutora Samantha. Nós temos aqui a Carla. A Carla é bióloga com mestrado e MBA. Ela é Senior Regional Manager Latino-Americana da Natera. E eu queria agradecer a Natera por esta oportunidade e por esse grande empenho que vocês têm em aumentar nosso conhecimento em todas as áreas. Muito obrigada, Natera. Sem vocês também não estaríamos aqui. E eu quero apresentar agora a nossa palestrante, doutora Samantha. É um grande prazer revê-la aqui novamente. Ela é a doutora Samantha Leonard, a diretora médica internacional da Natera. Ela tem um histórico único em genética clínica e ética médica, atuou no Reino Unido e na França, tem trabalhos e projetos em pesquisas pan-europeus na área de medicina genética, e ela consegue enfrentar os desafios de trabalhar na vanguarda de todos esses testes genéticos clínicos, né? Ela tem uma vasta experiência em ensino também, no campo da genética clínica e sequenciamento de última geração. E ela vai falar para nós aqui sobre o estudo SMART, é um estudo prospectivo da Natera sobre o NIPT, com mais de 20.000 pacientes. Vamos aguardar os detalhes vindos diretamente da doutora Samantha, mas é muito importante para nós esses estudos clínicos que eles fazem frente à nossa prática junto às nossas pacientes. Samantha, nice to meet you again. I think you can share your slides.
Thank you very much for letting me join you today to talk about this topic. I'll go ahead and share my slides. Oh, for some reason it's not working. Sorry about this. Okay, are you able to see my slides?
Yes, it's okay.
Great. Okay, perfect. Okay, sorry. My apologies. I don't know why we're having these technical difficulties here. Right. Right, okay. I'm going to try this one more time. Okay, excellent. Should be the right one. Okay, so thank you again for letting me join you to talk about this topic of new frontiers in NIPT and what can be achieved with different types of technology and with the addition of artificial intelligence to these technologies. So all of the non-invasive prenatal technologies are using the same starting material. So all of the tests use the cell-free DNA, which is of course the DNA that's found floating outside of cells in the mother's circulation. And so all NIPT tests are using this same starting material, but they're analyzing it in different ways. We know that the cell-free DNA comes both from the mother herself and also from the placenta specifically. And it's important that it's coming from the placenta because this explains why, in part, why NIPT is a screening test. So we know that in the vast majority of cases, the chromosomes in the placenta are the same as the chromosomes in the fetus, but occasionally there may be differences. So NIPT will always be a screening test. But there are other reasons that there can be differences between what is happening in the fetus and what the NIPT test result says. And so some of those can be addressed with the technological approach that is being used. So there are two major types of approach to analyzing the cell-free DNA fragments. The first approach, as you see over here on the left, is called the counting approach. And in the counting approach, what is happening is that these tests are identifying how many fragments in the mother's blood sample belong to a particular chromosome, like chromosome 21, and comparing these to how many fragments belong to a reference chromosome that they are using for comparison, like chromosome 3, for example, that they expect to be normal. And so they count all of the fragments that belong to chromosome 21 and all of the fragments that belong to chromosome 3. And they would normally expect to see a certain ratio of, say, 20% of the fragments coming from chromosome 21 to 80% coming from chromosome 3, because chromosome 3 is a much bigger chromosome. And so if this is what they would see, they would give that a normal or low probability result. But if they see extra material coming from the chromosome of interest, in this case, chromosome 21, then that would be given a high probability result. And the assumption would be that that extra material is coming from the baby. But this approach doesn't distinguish between fragments coming from the placenta and fragments coming from the mother. The Sniff approach is the other approach, and this is what is used by the panorama test. And a SNP is a single nucleotide polymorphism, and it's a single letter change in the DNA code. So we know that we all have hundreds of thousands of points along the DNA sequence where we differ from one person to the next. And these points don't cause health issues in themselves, but they do allow us to distinguish between one DNA profile and another DNA profile. So what this approach is doing in NIPT is analyzing 13,000 points along the chromosomes that we're interested in, where we expect to often see these small variations. And this allows us to distinguish maternal from placental DNA, and that allows us to do some interesting things. So each of those 13,000 points is analysed and looked at to see whether it says that the probability of trisomy or disomy or monosomy at each chromosome, to see which probability is the most likely. So why do we take this kind of different approach? It's because it allows us to do a number of interesting things. One is to be able to measure the fetal fraction in a bit more of a direct way, because we can see how much of that DNA contains genetic changes that come from the father rather than from the mother, and so analyze how much DNA in the sample is placental in origin. It allows us to spot when there are extra profiles there, like in the case of vanished twin, for example. So we know that a vanished twin DNA can actually persist for 15 weeks or more after the demise of the twin. And this is a well-recognized cause of incorrect NIPT results, because if your test can't see that there's an extra DNA profile present, then you may end up getting results that are actually for the vanished twin rather than for the ongoing pregnancy. So being able to be alerted to the fact that there is an extra DNA profile present allows you to reduce that kind of reason for an incorrect result. It allows you to see, similarly to indicative triploidy may be present. And it also allows you to see if whatever is happening in the chromosomes is actually on the maternal side. And we know that this is particularly an issue with the X chromosome. For example, women lose a copy of the X chromosome in a certain number of their cells, a certain proportion as they age. It's part of the normal aging process. But if the mother is missing an X in a proportion of her cells, then that could look like a monosomy X in the fetus. So again, being able to distinguish these different DNA profiles allows you to reduce some of those incorrect NIPT results. It allows you to tell the fetal sex with high accuracy. And then when it comes to twin pregnancies, it allows you to do some interesting things as well, like to tell the zygosity of the pregnancy, to give individual fetal fractions and individual fetal sexes. And all of these kind of things combined help us to reduce the incorrect results, the false positives and the false negatives. I just want to mention a little bit about twins, because I think that this is an area where it's easy to see how the technology really has an impact. So this kind of approach is the only one that's validated to determine zygosity. And it's beneficial to know the zygosity for a number of different reasons. One is that we know that dizygotic twins are virtually always dichorionic. Now, of course, chorionicity is assessed by ultrasound, but we know from studies that the ultrasound determination of chorionicity is not 100%. And so having the zygosity information allows you to put that together with the chorionicity from the ultrasound as a kind of double check. So if we find that the twins are dizygotic, it is extremely likely that they are dichorionic. If the twins are monozygotic or identical, then they could be dichorionic or they could be monochorionic, but it's a signal to the healthcare provider just to double check that chorionicity, to try to ensure that it does not look monochorionic, because of course those twins are at higher risk of complications. And then being able to tell the difference between maternal and fetal genotypes and differentiate the fetal genotypes allows you to give a fetal sex for each twin. Now, commonly, NIPT tests can just give the presence or absence of Y chromosome for the whole pregnancy. And they can't generally tell you whether there might be one male or two males in the pregnancy. And then importantly, it allows you to tell the fetal fraction for each twin. And this is really important because we know that although the overall fetal fraction, or the percentage of your DNA in the sample that comes from the fetus as opposed to from the mother, although the total fetal fraction in a twin pregnancy is on average higher than for a singleton pregnancy, we know that per twin, it is lower on average, and also that the fetal fraction can vary significantly between the two twins in a pregnancy. So if they are dizygotic, it is really important to know the fetal fraction for each twin in order to be able to know whether you have enough fetal material from each twin to be able to analyze. And finally, knowing the zygosity helps you with the calculation of aneuploidy for the pregnancy, probability for the pregnancy, because we know that the prior risk for dizygotic twins is actually very different than the prior risk for monozygotic twins. So knowing the zygosity helps with the calculation of prior risk and therefore the overall assessment. One of the things that is particularly important for us is the data to demonstrate how this method works. So this particular study, this first study that I'm going to share, was carried out by Dinono et al., and it's part of an ongoing quality assessment that we carry out every quarter. And this is to select between 200 and 400 high probability result cases to follow up to find out whether those results were confirmed or not in the fetus. And this helps us to know the positive predictive value for the test. And the positive predictive value is very important to know because it tells you the likelihood that a high risk or high probability result from this test will be confirmed in the fetus. So we know that the positive predictive value, because of the way that they are calculated, statistically, they are lower when the incidence of a condition is lower. And this is important because we see now that an increasing number of younger women are using NIPT, and in younger women, the prevalence of trisomy 21 is lower. And that means that the positive predictive value will be lower in that group than it will be in women of a higher age with a higher prevalence of trisomy 21. So it's really important to know, how does your test perform in different age groups? So that's what we wanted to study here. And what we found was that, that yes, there is, as expected, a difference in the positive predictive value between patients who are in the under 30 age group over here on the left, and then patients in the over 40 age group over here on the right. But across all of these different age groups, the positive predictive value is over 90%. So we would expect over 90% of high probability results to be confirmed. If we look at some other tests, we see that this is not always the case. So this first test shown here in green, we see that the positive predictive value decreases in that younger age group significantly. So in that youngest age group, it goes down to 74%. And then this test here in grey actually falls all the way down to 35%. So for that particular test, if it's being used in women under 30, it means that a high probability result is actually more likely not to be confirmed than it is to be confirmed. So this is important information when counselling women. So it's really important to know, how does the test that you're using perform in the different age groups? And then I want to talk to you about this latest study that we have. This is the SNP-based microdeletion and aneuploidy registry study, or SMART. And this was a very comprehensive kind of study to really determine how the test performs. So the initial objective was to look at how this SNP-based panorama test performed for the common trisomies and the microdeletions in a large general cohort of pregnant women, and to get follow-up on all of the cases, whether the NIPT result was high probability or low probability. So this makes it really unusual because studies of NIPT follow up the high probability cases, but they don't try to follow up every single low probability case because there are so many more of those. But that's what happened in this study, that we did follow up those cases. So we recruited over 20,000 women in 21 sites across the world. And we managed to get genetic outcomes in over 88%. So the recruitment went on for a long time, as you can imagine, between 2015 and 2019. And then we did another thing with that data. We reanalyzed it using an artificial intelligence algorithm. And I'll explain a little bit about that in a moment. And when I say that we got genetic outcomes, what I mean is that we analysed postnatal microarray specimens, and those were run at an independent laboratory, and they were run on all of the cases, whether they were high probability with NIPT or low probability. The artificial intelligence, this machine learning program was developed on information, data from over 2 million tests that had been performed in our laboratory to train the system to recognize different situations. And so what this allows you to do is to get results in some of those borderline cases that the previous algorithm would not have been able to call. So those results previously would have received a no call and perhaps a request for a repeat sample. But with the artificial intelligence algorithm, it's possible to make more calls in those difficult to call cases, but importantly, to maintain the accuracy of the original version of the test. And it also allowed us to go further with 22q11 microdeletion to detect some of the smaller nested deletions. So this was the largest NIPT validation study to get genetic truth on all participants. It showed that the aneuploidy performance was consistent with the validation studies that we had carried out when we first started using the test, which is what we hoped that it would do. And it showed that we can reduce the no-call rates using this updated algorithm. And finally, that it was possible to significantly improve the detection of 22q11. And we noted that test failures were associated with adverse pregnancy outcomes. This is preliminary data, but it was interesting because it shows that those failed samples may be telling us something about the pregnancy. So you can see here the results for the original version of the test and the artificial intelligence version. And you can see in blue here that the original version of the test for the common trisomies performed with very high sensitivity and specificity. And that the artificial intelligence algorithm, shown here in gold, you can see that the sensitivity and the specificity is virtually identical, but it was possible to give more results. So it's possible to give an extra 2 correct high probability results for trisomy 21 and trisomy 13. And it was possible to give extra low probability results as well. And this is important because there's always been a kind of compromise in NIPT between being able to give as many results as possible, but also to keep the false negative rate as low as possible. So some tests do not measure the fetal fraction, or they do not use it as a quality metric with a threshold. With Panorama, we've always had a threshold below which we do not give results. We would prefer to ask for another sample to be sure that we have enough fetal DNA to analyze. And so this has meant that the no-call rate has been a little higher, but the false negative rate is lower. However, with this new artificial intelligence algorithm, it's possible to give more results. And so to be able to reduce that no-call rate, in the cohort, the original algorithm had a no-call rate of 3.3%, and it was possible to reduce that down to 1.46%. And after a redraw, it was possible to reduce it even further to 0.61%. I mentioned that we also saw that when there were 2 no-calls, this is using the original version of the algorithm, this is the data that's been analysed so far, it indicates that if you have 2 no-calls, then the rate of non-live births for any reason, including fetal demise, stillbirth, termination, is increased, preterm births are increased, and pre-eclâmpsia are increased. So this data is still being analysed, but it's an interesting indication that these double no-calls are giving us perhaps some information about the pregnancy, and it may warrant further surveillance. And finally, I just want to mention briefly about 22q11 syndrome, which is the other part of the data that we have had results for so far. 22q11 syndrome is interesting because it's the most common human microdeletion. It's often unrecognized at birth, so parents can go on a long diagnostic odyssey. And it's associated with a number of features. Now, it's variable, so some children will have none of these features, some will have some of the features, and some may have all of the features. But it's associated with things like congenital heart defects, developmental delay, immune deficiencies, hypocalcemia and seizures, and schizophrenia. And we know that for many of these features, if you can act early, then you may improve the outcome. For example, neonatal hypocalcemia and the seizures that are associated with it are both associated with more severe intellectual disability. So if you can identify the low calcium and act, then you may help to maximize the outcomes for that child. Similarly, with cognitive development, we know that language development in particular is a challenge. And we know that there are therefore a number of opportunities for early intervention with early speech therapy and developmental therapies. 22q is more common than some of the other conditions we routinely screen for, such as trisomy 13 and trisomy 18. And unlike the trisomies, it doesn't change with increasing maternal age. So this means that actually younger women have the same risk of, or have a higher risk of having a baby with a microdeletion than they do of having a baby with trisomy 21. The main deletion in 22q11 is this full A to D deletion of 2.5 megabases, but we know that you can get smaller, what we call nested deletions within that region, and less commonly deletions even outside of that region. But one of the interesting pieces of information to come out of the SMART study was that a higher than expected proportion of all of the 22q deletions in the cohort was these smaller deletions. So this is how the test performed. We saw that the original version in blue, again, detected 9 out of 12 deletions, so a sensitivity of 75%. And the artificial intelligence algorithm was able to detect an additional deletion, giving a sensitivity of 83%. And importantly, the positive predictive value using the artificial intelligence algorithm was increased from 23% with the original version up to over 50%, really bringing it in line with other aneuploidies that we routinely screen for, like trisomy 13 and monosomy X. You can see that the fetuses that had ultrasound scans in the first trimester that had 22q deletions, none of those had any abnormalities. And you can see that there were 4 cases where anomalies were detected before NIPT, and those were the cardiac anomalies that you can see here. The American College of Medical Genetics recommends discussing the availability of non-invasive prenatal testing to look for clinically relevant copy numbers. And the International Society of Prenatal Diagnosis says that screening for microdeletions and duplications should be limited to clinically significant disorders or well-defined severe conditions, and there should be information about the performance of the test. And so that is what we were trying to do with this study. 22q is a well-defined syndrome. There are early intervention measures and support groups available. So just to conclude, using artificial intelligence can enhance SNP-based NIPT to be able to give results in more cases, but maintaining the accuracy of the SNP-based approach. SNP-based cfDNA screening can actually detect most cases of 22q11 with a low false positive rate. And the nested smaller microdeletions of 22q11 are more common than previously reported and should be included in performance analysis and counseling. So thank you very much for listening to my presentation.
Thank you, Samantha. It was a wonderful presentation. Conseguem me ouvir, Carla? Okay. Thank you, Samantha. It's very important for us, your positive valor preditivo positivo, your PPV, because our population here in Einstein, we have a high maternal age in most of patients, and we are indicating an NIPT. Now I will pass voice to doutora Renata. Olá, Renata, por favor, suas dúvidas para a doutora Samantha, e depois a Carla vai nos ajudar com dúvidas que vocês podem estar colocando no chat, por favor.
Obrigada, doutora Rita, pelo convite e pela oportunidade de sempre poder debater NIPT, que é um assunto que revoluciona aqui o cuidado materno-fetal, né? E a gente aqui, que está no laboratório diariamente, tem constante contato com a equipe da Nesta. A gente faz bastante consultoria aí com alguns casinhos que são super interessantes de se acompanhar e a gente aprende diariamente, né? Eu queria saber se eu adresso as questões para a doutora Samantha em inglês, direto para ela, ou se a Carla prefere fazer a ponte, fazendo a tradução para ela.
Renata, eu acho que você pode perguntar para ela em inglês. Eu vou ajudar, mas quem tiver pergunta e quiser mandar pelo chat, quiser mandar em português, pode mandar que eu transfiro para a doutora Samantha. Mas acho que você pode mandar em inglês direto.
Tá bom, então. Samantha, thank you for explaining all your detailed data about the SMART study to us. I was very impressed with all the numbers you were able to create and show us. I would like to know more specifically about the data regarding the 22q11 deletions, the nested deletions. You show us the sensitivity of the detection of the nested deletions was up to 83%, if I am not wrong. But could you be a little more specific regarding the technical issues about detecting these small deletions? Because the smallest deletion is up to 0.5 megabases, is that right? How can a SNP methodology can detect so small deletions such as this one?
Yeah, so thank you for your question. So the sensitivity is for all of the deletions combined. The reason that it's possible to achieve that kind of level of sensitivity is partly because the method is targeted. So with NIPT, you kind of have a choice that you can make between trying to look across the whole genome or focusing your test in specific areas. And we strongly feel that that the most effective way to get the most clinical information from an NIPT test is, rather than trying to look everywhere at a sort of less sensitive level, to actually really concentrate your test within certain areas, because the more you concentrate the test, the more times you can read each piece of DNA, and the more times you can read each piece of DNA, the more accurate you can be and the more sensitive. So that is what we have chosen to do, is to target our test. And what we see when we do that, interestingly, is that you actually, although it might seem instinctive that if you look across the whole genome, you're going to get more information, what we actually see is that that kind of approach leads to decreased sensitivity for some of the really important conditions like 22q11. So because that's the most common microdeletion, and because it's an important condition in terms of being something where early intervention may make a difference, we have chosen to concentrate our test specifically to the chromosomes that we're interested in. So we focus all of our sequencing power on those specific areas, so chromosomes 21, 13, 18, and then these specific small areas of microdeletions that we're trying to look at. And then we have the SNP methodology, which itself helps us to look in great detail at an area. And then with the artificial intelligence algorithm as well, that is very highly developed to recognize different patterns. So all of those things combined help us to be able to pick up even those smaller deletions. And it's important because as it happens, we showed in the cohort that those smaller deletions account for a bigger proportion of all of the deletions than we previously thought. So it was good to be able to show that even when you are trying to detect all of the different deletions within that A to D region, we can still maintain, or we can still achieve, a sensitivity of 83%. So that's basically how.
Thank you for your great answer. It was very important to get to know all the technical issues regarding the detection of these nested deletions. I was wondering if Panorama AI would have something to do with it. And I have just a couple of more questions. One would be, are Panorama reports already being issued using Panorama AI, or do you plan on implementing it anytime soon?
Yes, so the artificial intelligence algorithm is being implemented in stages through the course of this year. So already we have implemented the part of it that is allowing us to reduce the no-call rates. Sometime during the summer, I believe around July, we should see updates of the reports to reflect the other aspects of the test, the changed positive predictive values for the main chromosomes. And then by the beginning of October, I believe, that kind of time, we should by then see all of the changes that are brought by the artificial intelligence algorithm. So yes, it's already underway and will be fully established certainly by the end of this year.
Okay. Just two more questions. Does Panorama AI would be able in anytime soon to detect more than 3 different DNAs in the algorithm? Because as far as I know, Panorama can differentiate up until now 3 different types of DNA. Is that correct?
That's absolutely correct, yes. So we always say that we can cope with one mother and two babies, or two mothers and one baby. In other words, if you have a surrogate pregnancy using, well, if you have a donor egg for any reason, then you have the mother who's pregnant, you have the DNA of the egg, so that's the kind of two mothers, and then one baby, or the mother with twins. And you're correct, at the moment the algorithm isn't developed to be able to manage pregnancies higher than that. I would hope that that eventually that will become possible using that kind of advanced machine learning, but at the moment it's still the 3 DNA profiles.
Okay, so that could happen. We don't know when, right?
I couldn't tell you a date, a time.
Okay, okay. The last question would be like an extension of this one I just made. Does Panorama AI would have a potential use of expanding the microdeletion panel for twin pregnancies or surrogate pregnancies?
Yeah, so that's a really interesting question as well. I think there are many possible things that could be done with this kind of technology. I think that for the moment we're just assessing its use in the way that we've used it so far, and I'm sure that in the future it will be assessed and applied to different areas, and hopefully to be able to do new and exciting things with the test. So I'm sure that there are definitely more and newer things to come in the future, and we will of course share those with you as soon as we have any more information.
Hello, Sam. We have
Thank
a
you.
question from Dr. Renata Gomes Castelo here on the chat. In the case of monozygotic gestation, is it possible to identify de novo microdeletions only in one of the fetus?
So my understanding is that the question is, would we know in monozygotic twins if a microdeletion was only affecting one of the two twins? So the answer is that no. If we're giving a microdeletion result, it would be for the pregnancy. It would be really unusual. I don't say impossible, because in genetics nothing is impossible. It would be unusual for monozygotic twins for one of them to have a microdeletion and the other one not to have it. It's not completely impossible, but it would be unusual. But in any case, even if that did happen, if we gave a microdeletion result, it would just be for the pregnancy. It wouldn't be possible to tell you currently whether we thought that the microdeletion might be affecting one twin or both. And that's the same for the aneuploidies as well, that if we give a result, it's a result for the whole pregnancy, rather than for saying that it's in one twin or both twins for the chromosome anomalies.
Okay, and just to add, in the case of twin gestation, we only access 22q microdeletion and only in monozygotic gestations. Okay, just to add, not the other microdeletions. Another question from Dr. Adolfo Leal. The increased rate of preterm deliveries in the no-call group, can you tell which proportion of those were spontaneous preterm births?
Yeah, thank you. I think that's a really important question, and we're looking into that data at the moment. So as I mentioned, this is quite preliminary data, and the principal investigators in this study are still looking at many aspects of the data, and I know that they are digging further into this adverse events, because this is something that that was very new and interesting. So I can't tell you at the moment which proportion were spontaneous preterm births, but we expect to be able to have that level of detail as we get more of that information back. So, so we should be hopefully able to update you in the future with more information about those adverse outcomes.
Perfect. I don't know if Dr. Renata asked about egg donation. Renata, you asked about I lose?
I think she
Not
did. She was
specifically.
mentioning.
Not specifically.
I think when she asked about 3 DNAs, I think maybe she was thinking about egg donation and twin gestation. And yes, that's what Sam said, that we are not able to report.
So when we have one fetus only and egg donation, it's possible, right, Samantha?
Yes, that's correct. So three DNA profiles. So either 2 maternal profiles, one the genetic material from the egg and the genetic material from the mother who is carrying the pregnancy, and then the one fetus. So yeah, we can manage 3 DNA profiles at the moment, whether that's twins or whether it's the egg donation or surrogacy situation.
Okay, perfect. More questions? Let's see.
Yes, there is another question. If we report mosaicism ratio?
No, we don't.
Can you just tell a little bit of which mosaicism report we provide, just like mother's mosaicism?
Yeah, so mosaicism is outside of the scope of the test. So what we're screening for is our full trisomies of 21, 13, 18. We do report sometimes, as I mentioned, the mother can have an anomaly of the X chromosome, including a mosaicism of some sort. And in the cases where we see a maternal anomaly on the X, which is then affecting the test, then we will report that there is a maternal anomaly. What we don't specify what kind of anomaly, so the kind of things that could cause that are some kind of mosaicism. We've done a study which the publication of which we could share with anybody who's interested, and it shows that some of them were mosaic Turners, some were full triple X, I think. So there were a variety of different maternal X issues that could affect the NIPT test. And in those cases, where we can see that it looks like a maternal issue, then we will report that we suspect a maternal X anomaly, and then appropriate investigations can be carried out. And it's important to note that in those cases, what that means is that it is not possible for that woman to analyze the X chromosome of the baby using NIPT. So this is important information because it means that it will be the same for ongoing pregnancies. Whatever the issue is with the maternal X, it's affecting the ability of any NIPT test to see the fetal X. So we can't comment on the fetal X. Which means that if you wanted to look at the X chromosome, if that woman wanted to look at the X chromosome in that pregnancy or future pregnancies, then they would need to use a different method, not NIPT of any sort. If they want to look at the other chromosomes, then normally that would not be a problem. But for the X, if the mum has something happening with her X chromosome, then the test isn't going to work reliably for the fetus for any NIPT.
Would that be the case for a false positive as a Turner syndrome with another NIPT?
So it could be, yeah. I think the problem is that you just won't know. We know that with our test, we have this possibility to see that there's an issue on the maternal side, and to be able to help to avoid reporting some of those false positive Turner syndrome. Now, this does not mean that there will never be false positives for Turner syndrome. Panorama, like every NIPT, is a screening test, and there will be false positives and false negatives. But the technology allows us to reduce those by being able to do things like having the possibility to say that an issue is on the maternal side. If you ran the same test using another NIPT, you wouldn't be able to see whether or not what the test was seeing was maternal or fetal. And so you wouldn't know whether a result that you got back that was abnormal was really reflecting the fetus or whether this was just reflecting the mother, which is why the suggestion would be that NIPT for the X chromosome would not be the best screening test in that case.
Thank you, Sam. We have another question from Dr. Adolfo Leal, a comment and a question. A great effort was invested to create the new AI algorithm, and new interesting findings associations have arisen. How can it be continuously uploaded with new real-world data to investigate further improvement and findings?
Yeah, so I think this is really exciting technology. I think that there are many possibilities to be explored. I think that that what we always have to do is to make sure that any changes that we make are validated, and that's why this artificial intelligence algorithm was, the decision was made to validate it using this large cohort of patients that we had through the SMART study. And so the really important thing is to make sure that anything you do to a test is fully validated and fully performs as you would expect. So I think that there are many possibilities with it, and I'm sure that we will eventually see new things happening with it and new possibilities. And whatever we do, we will always make sure that that everything is really thoroughly validated. So yeah, I think this technology brings lots and lots of exciting possibilities, and we were very happy to see how well it performed in this cohort.
Great. We see we don't have questions in Facebook. We are transmitting. Você viu mais questões aqui, Carla? Acho que não, né?
Não tem mais perguntas aqui, não.
Eu tenho uma última pergunta. Quando vocês vão... quando será publicado o estudo?
Sam, do you know when it will be published? This month?
So it has been submitted for publication, and we are waiting to hear back. So as soon as we get that information, we will share it. But I don't have a date at the moment. It's being looked at by the journal.
Excellent. We are waiting for. And estamos pedindo para vocês preencherem nossa pesquisa de satisfação no chat, por favor. Temos um link do ensino, deem suas opiniões. E eu acredito que se não tivermos mais perguntas, talvez a Samantha queira dar algum comentário final, ou a Carla.
Sam, do you have any final comments? We don't have any questions anymore.
No, I just want to thank you for all the very important and relevant questions that were asked, and I hope that that I've been able to answer those, and to encourage everyone that if they have further questions, that they can always contact myself or Carla, and we will try to answer those for you.
Ok, thank you, Samantha. Pode falar?
Desculpa. Eu também só quero agradecer por essa parceria, agradecer a doutora Rita, o time de educação, a doutora Renata, o time do laboratório, e agradecer o pessoal que atendeu as perguntas, e eu fico à disposição também para qualquer dúvida, posso repassar para a Samantha quando vocês quiserem algum artigo. Eu vi que teve uma pergunta a respeito de mosaicismo na gestação, e que a Sam disse que a gente tem uma publicação interessante. Então, fiquem à vontade para pedir. Muito obrigada.
Thank you, Samantha. It was wonderful. Eu também estou à disposição de todos que estiveram conectados. Também faço essa ponte com a Carla, e a Carla tem sido fantástica em nos ajudar nesta ponte com a Nesta. Muito obrigada a todos e aguardamos o artigo.
Thank you.